I think we'll make a start. So good evening, everyone. Thank you for coming to D for Drugs, the fourth event of our ABCDP of Anesthetics webinar series. I'm Rachel, and I'm one of the co-chairs for the Pre-Vocational Anesthetics and Critical Care Society, an interest group for medical students and junior doctors interested in all things anesthetics, crit care, and pain medicine. We're hoping to keep this session short and sharp, so about 30 to 40 minutes. And at the end, we'll have about a 10-minute Q&A via Slido at the end. So please submit your questions via the Slido link, which will be posted into chat and throughout the event. So to begin, I'd like to pass on to our sponsor for tonight's event, Amanda from Dr. On-Call Locum Agency. They're a medical locum recruitment service placing locum doctors at hospitals and events from across Australia. And I'll just stop screen sharing. It's all yours.
Great, thanks so much for that. Okay, evening everyone. I just wanted to jump on tonight and just give you guys a little bit of information about Dr. On-Call. Now you should see up on your screen now a QR code. So if anyone here is interested in doing any locum work at all, if you want to scan that, pop in your details, we'll email you through some info about locuming with Dr. On-Call, and then have a chat to you about what you might be interested in. So just a little bit of information about us. We provide doctors to hospitals throughout Australia, both public and private hospitals. We've been around since 2007, and we've started by 3 doctors who saw a bit of a gap in the locuming space and wanted to jump in and do something about that. We also offer a personalised recruitment experience where we all work with you individually to find out what you want, find the jobs that fit in with your need, your experience, and also with your financial expectations. We have coordinate all the transport and accommodation for jobs where there are accommodation and transport included. We do all the compensation negotiations on your behalf, taking into consideration your experience and your expectations financially. We'll negotiate all the shifts. We'll also look after all the invoicing and chasing up payments on your behalf as well. And our customer service team is available 24/7. So if you're on a job and there's any issues at all, you'll always be able to get somebody on the phone. So we have a large network of hospitals throughout Australia in all capital cities and a lot of regional areas as well. We have some really great incentive programs as well. So one of those is for our new doctors that come on board. We've got our performance boost. For every 5 shifts, up to 15 shifts, you'll receive a monetary bonus at the end of those shifts. Once you've done the first 15 shifts, you then move into our next performance boost area, which is our health check, where you go into a draw for $5,000 at the end of the quarter. And then that's whoever wins that's paid by a bank transfer. And then for any of our doctors that refer a friend, they'll receive a $500 Westfield voucher for every friend that they refer that comes on and does at least 1 shift with us. So that's the basics with Dr. On-Call. For anyone that is interested, as I said, if you want to scan that QR code, pop in your details, and then we'll be able to get in touch and have a bit more of a chat about what you might be after. So thank you all for your time, and I hope you enjoy your training session tonight.
Thank you, Amanda. Thanks for your presentation, and hope you have a good night.
Great, thank you.
Thanks. See ya. All right. Now I'd like to introduce our speaker for tonight's event, Dr. Patrick Beall. Patrick is a second-year anaesthetics registrar at St. Vincent's Hospital. He graduated from Deakin University and spent his internship through to PGY3 at St. V's before joining the Eastern Training Scheme for Anaesthetics. And his current anaesthetics interests are regional and cardiac anesthesia. And outside of medicine, his hobbies include piano, music production, yoga, psychology, religion, and teaching, of course. So thank you, Patrick, for coming to speak for us tonight. And you're already sharing your screen, so I'll just let you take the reins.
Sorry, just trying to figure out that unmute. I think that's good. Can you guys hear me?
Yeah, we can hear you.
Yep.
Yeah. And my cat's come up. So over here as well.
Oh.
All right, groovy. So I'll just go full screen. Actually, that's going to be a problem. Okay. So I've got two screens here. Just one sec.
And we just see the one slide. So I think that's working.
All right. Nice. Okay. So that's a bit about me. So I'm a St. Vincent's trainee. So I'm in my second year of training. So I've finished my primary exam now and sort of enjoying the post-exam life. Next year I'll be doing an OPAT year. So that's obstetrics, pediatrics, and more advanced training. And then after that, I'll be doing another advanced training year and hopefully passing my final exam and then going on to provisional fellowship. So I was tasked with doing a presentation on pharmacology and anesthesia, which is obviously, it's a huge topic, but I want to try and sort of pierce apart maybe the key pharmacological principles governing general anesthesia, local anesthetics, and cardiovascular drugs. So a good way to conceptualize general anesthetics is the classic anesthetic triad, which some of you have probably heard of before, consisting of hypnosis, so putting someone to sleep, essentially, muscle relaxation, and analgesia. And we're going to use this part of the classic triad to take us through a journey of anesthesia. So a journey of anesthesia consists of induction, maintenance, emergence, and recovery. And each of these three factors are going to be important during each part or each of those four anesthetic stages. And then you might ask yourself, what is general anesthesia? So there's a good definition of general anesthesia. So this is one. So it's a reversible iatrogenic state characterized by unarousable unconsciousness and reflex depression. So it's not enough just to have unarousable unconsciousness. You also need reflex depression, and those reflexes consist of somatic, autonomic, and neuroendocrine. And this is where our anesthetic triad comes into place. So we'll come back to this definition in mind, and we'll go back through the classic anesthetic triad. So for hypnosis, the two common agents that we use for hypnosis include the IV anesthetic agent propofol, very commonly used for induction, and also can be used for maintenance via total intravenous anesthesia, so called TIVA, or the other way to do it is via volatile anesthetics, the most common one being sevoflurane, the other ones being desflurane and nitrous. Volatile anesthetics can also be used for putting patients to sleep, and this is commonly done in the pediatric population. So that's how we're going to put someone to sleep. The next thing we need to consider is muscle relaxation, and that can be broken down into the depolarizing and non-depolarizing muscle relaxants. So we'll come back to this definition in a minute. But the main thing with muscle relaxations is we're going to use it for our induction. And the reason we're using this is we need the muscle relaxation. It's going to open the cords and relax the cords for us to pass the tube, but it's also going to improve our airway view. So it's taking us from a grade 3 to a grade 2, or from a grade 2 to a grade 1. The other thing that we're going to use muscle relaxation for is during the maintenance of anesthesia is for surgical access. So the surgeons, if they're doing surgery within a cavity, such as in the chest cavity or the abdominal cavity, then they will want the muscles to be relaxed. So a laparoscopy is a good example of a case that needs to be done under muscle relaxation. The image to the right here, this is a patient having a craniotomy. So you don't need the muscle relaxation for surgical access, but it's very important for the muscle to use the muscle relaxation in this case to minimize the coughing or even subtle small movements of the patient, which could be potentially catastrophic. The next part is analgesia. And you might get into a philosophical argument whether someone who's anesthetized experiences pain but you don't need to, because pain and reflex arcs are very closely tied. So if you have pain, you'll get increase in your reflex arcs being motor, so you're localized. You'll have increase in your respiratory rate, and your sympathetic drive is going to go through the roof. So we controlled those reflex arcs with opioids, but other analgesics that we use include non-steroidals, paracetamol, and other drugs such as ketamine, clonidine, and regional. So a good example of this is, let's say you put someone to sleep with an IV or with a hypnotic agent, and then you give a muscle relaxation, and then you try and put an airway in. So you try and put an endotracheal tube into the airway. You'll see that the blood pressure will shoot up from 120, systolic 120 to over 200. So we give our opioids on induction, not so much for analgesia, but more for reflex depression, because we don't want that blood pressure shooting through the roof. So we come back to our definition of general anesthesia. So unarousable unconsciousness, so that's the hypnosis part of it. So that's going to be propofol or sevoflurane. Then there's the reflex depression part of it. So there's the somatic reflexes, which we can control with opioids and muscle relaxants, and to some extent sevoflurane that acts also at this, the level of the spinal cord. And you also inhibit autonomic reflexes. We had a good example of that with opioids and having a tube in the airway. And neuroendocrine reflexes, which is controlled via opioids, propofol, and sevoflurane. So that is how our anesthetic triad is going to plays into that definition of what is general anesthesia. So let's have a case that we can maybe go through and think about. So we got a 27-year-old chap who's got acute appendicitis. He's in a lot of pain. He's nauseous. He's vomiting. His obs are all within normal limits. He's been adequately resuscitated. He has got no significant past medical history. So the surgeons want to do a laparoscopic appendectomy. So you ask yourself, what drugs do you reach for? So we're going to think of this case in terms of our anesthetic triad. But importantly, before we get cracking, you should have some alarm bells ringing. So this patient is at risk of aspiration because they've got pain and they've got a lot of nausea and vomiting. So you've got to assume that their stomach's not empty and there could be some content in there. So if you bag mask ventilate this patient after you induce them, there's a possibility that you'll insufflate their abdomen, their stomach, and that would cause them to ask the food or whatever contents are in their stomach to come back up the esophagus and then soil your airway and potentially lead to morbidity and mortality. And that's a serious concern that anaesthetists have. It's probably one of the highest concerns that any anaesthetist has whenever they're inducing a patient. So therefore, we're going to do a rapid sequence induction. So you're not going to bag mask ventilate the patient. Instead, you're going to ensure adequate pre-oxygenation, because that's going to buy you apneic time so that you've got time to get your airway in. You're going to apply cricoid pressure. So the cricoid cartilage is it's a circular cartilage. You can feel your thyroid gland, then you got your membrane underneath, and then you got your cricoid. And the cricoid is it's a circular structure. It's cartilage all the way around. So if you press on it with adequate force, then you can actually occlude your esophagus, which is what you're trying to do in this instance to prevent food from going up your esophagus. You want to minimize the time between induction and intubation. So you're going to give your drugs pretty quickly, and you want a neuromuscular blocking agent that has very quick onset, because that's really your rate determining step to intubation. So what a neuromuscular blocking agent are you going to use? Either suxamethonium, so that's a depolarizing neuromuscular blocking agent. It has a very quick onset. You can see its onset based upon it having fasciculations, and the cessation of those fasciculations means that it's working. And its duration of action is very short, only 10 minutes. The other option is to use rocuronium at a higher dose. Because rocuronium is not a very potent anesthetic, it means that you can give higher doses, and therefore via fixed law of diffusion, it has a quicker rate of diffusion into the neuromuscular junction, and therefore has a quicker onset. So that's a non-depolarizing neuromuscular blocking agent. Its onset time is maybe a tiny bit longer than suxamethonium, but still around 1 minute. You're not going to get those fasciculations. but its duration of action is going to be very long. So it's going to be more than an hour. So other reasons to consider rapid sequence induction. So unfasted patients, patients got bowel obstruction, or they've got a nasogastric tube in that's adequate, that's continuously bringing stuff up. Someone who's got delayed gastric emptying. So for example, gastroparesis from poorly controlled diabetes or from medications or opioids can reduce your gastric emptying. Or trauma. So trauma, if you have an increase in sympathetic spike, then you need your parasympathetics to rest to digest. As if your sympathetics are through the roof, then you're not going to rest to digest. So the food's just going to sit in your stomach. So even if someone's fasted for 10 hours, but they've had a major trauma, you need to treat them as though they've still got a full abdomen. And the other reason would be an impending airway obstruction, pregnancy in the second trimester, they get physiological changes, which again put them at higher risk of aspiration, and severe reflux disease would be another reason. So this is the drugs that we're going to use for our anesthetic. So induction, we're going to do rapid sequence induction. We're going to use fentanyl at 2 to 3 mics per kilogram. So it's going to be about 200 mics. Alternatively, you could use alfentanil, which is a shorter acting, quicker onset opioid. So we're going to use a hypnotic agent, so it's going to be propofol, typically dosed at 2 to 3 milligrams per kilogram if the patient's well, but depending on hemodynamics and other factors. But typically for a young, well patient, you would give around 200 milligrams. And suxamethonium, so that's dosed at 2 milligrams per kilogram, and you're going to give about 100 milligrams of that, and that's going to facilitate the tube. Then we're going to maintain our anesthesia, and we're going to do this, say, in this instance, sevoflurane, so that's the volatile anesthetic gas. The other way we could do it is with the propofol and just give that as an infusion, as maintenance. And then we want to keep their reflexes and pain under control with frequent doses of opioids, so fentanyl, or people commonly give oxycodone in otherwise well patients. And then we want to keep the surgeons happy. So we're going to give them non-depolarizing neuromuscular blocker to maintain surgical access. So either rocuronium, vecuronium, atracurium, or cisatracurium. So you can't just keep giving suxamethonium. The reason being is that you'll then develop a different kind of block, and it becomes a lot less predictable. So suxamethonium is only for single use only, and then you need to give a non-depolarizing neuromuscular blocking agent. Then on emergence, we're going to give a reversal of our neuromuscular blocking agent, and we're going to ensure adequate analgesia. Other considerations: multimodal analgesia, antiemetics, IV fluid, and maybe sympathomimetics to manage the hemodynamics. And in terms of reversal of neuromuscular blocking agents, you can either do that one of two ways. It's either via neostigmine or gammadx, and I'll go into that in a bit more detail in a second. So if we're thinking about our neuromuscular blocking agents, it's important to have an idea of where they're acting. So this is a motor neuron. So this is coming from your spinal cord, and then it's supplied, the neuron is going to your muscle fiber. And you've got this interface between the neuron and the muscle. It's called the neuromuscular junction. So if we zoom into that neuromuscular junction, so we get an impulse coming down the axon, so the voltage-gated sodium channels open, and it causes propagation of an action potential. And then the action potential arrives in the neuromuscular junction. This causes depolarization at the synapse, and this causes influx of calcium. This calcium then binds to the vesicles which contain acetylcholine, which then are released into the neuromuscular junction. The acetylcholine then can bind to the nicotinic acetylcholine receptor, which then causes an influx of sodium at the end plate. Which is in the muscle, but it's called an end plate potential. Then if you get adequate end plate potential, then you can achieve an action potential. And this goes down the T tubules, causes a depolarization, influx of calcium. Calcium is then released from the sarcoplasmic reticulum, and then you get binding of that actin myosin. So it binds to the troponin C, which binds to the calcium on the actin head, and that unfolds the myosin binding head, and then you get a power stroke, so then a contraction of the muscle. So all our neuromuscular blocking agents are acting at the nicotinic acetylcholine receptor at the neuromuscular junction. So that's where all of them are acting. So if we think about types of neuromuscular blocking agents, we've got the depolarizing and the non-depolarizing. So the depolarizing is succinylcholine. That's really the main one that we're using. And that's an agonist at the nicotinic acetylcholine receptor. And it's not metabolized by acetylcholine esterase, which becomes very relevant. And then you've got these non-depolarizing, which can be broken up to the aminosteroids and benzoisoquinoline, so rocuronium, vecuronium, atropurium, and cis-atropurium. And these are all competitive antagonists at the nicotinic acetylcholine receptor. So the competitive antagonists, and what they're doing, they're out-competing acetylcholine for their binding site at the nicotinic acetylcholine receptor. So if the non-depolarizing muscle relaxants binds, then it means that acetylcholine can't bind, and therefore the channel remains closed, and therefore that causes relaxation. Succinylcholine is different. So it's an agonist. So it binds, it actually causes the channel to open, sodium rushes through, it causes depolarization and contraction. But the thing with succinylcholine is that it's not metabolized by acetylcholine esterase. So that's the esterase in the neuromuscular junction. So therefore it's not metabolized, so it stays bound. And you actually, the channels don't actually like it when they stay bound, and because for them to keep working, they need to go through this period of resetting, and they can't reset if the succinylcholine stays bound. So it goes into this strange opened but blocked configuration where it's bound, but it becomes closed and inactivated, and it can't reset the cycle. It can't go back to closed normal. So then we can think about how we're going to reverse each agent. So for succinylcholine, you can't give any reversal. There's nothing available for you. But fortunately, its duration of action is very short. But the caveat to that is for patients with acetylcholine esterase deficiency. So people, you might have heard of sux apnea, and that's with people with deficiencies in this enzyme, and therefore they have a prolonged duration of action of succinylcholine. Sorry, not acetylcholine esterase, it's butyrcholinesterase. Sorry, that's a mistake there. So duration of action is 10 minutes if normal plasma colon esterase. So plasma colon esterase is different from acetylcholinesterase. Plasma colon esterase is only within the plasma, and the plasma colon esterase, you can have dysfunctions in that enzyme if you based upon certain genetic conditions. So that's what sux apnea is. Whereas reversal for the aminosteroids, you've got two options, either neostigmine or gammadx. But for the benzoisoquinoline, you only have one option of reversal, which is neostigmine. Obviously, these non-depolarizing neuromuscular blocking agents will also wear out typically after about 40 minutes after a standard dose. But if you give rapid sequence induction dose of rocuronium, which is twice the standard dose, then its duration of action is going to be at least an hour in most instances. All right, so in terms to understand the reversal agents, it's important to understand what is going, or the different types of acetylcholine receptors. So your somatic system, so that meaning your motor neuron, is where your neuromuscular blocking agents are working. So that's what we were looking at before. So that's got the nicotinic acetylcholine receptors, specifically the nicotinic muscular acetylcholine receptors. So that's where our neuromuscular blocking agents are. But you also got acetylcholine receptors elsewhere in the body in your autonomic nervous system. So your autonomic nervous system consists of the parasympathetic and the sympathetic, and they've got these muscarinic acetylcholine receptors. So our neuromuscular blocking agents do not work there. So they're not interested, they don't bind to these sites here. They only bind to the nicotinic acetylcholine receptor. Your parasympathetic, so that's rest and digest pathway. The sympathetic, it's mainly noradrenaline and the adrenergic receptors, but it's also got a muscarinic acetylcholine receptor at the sweat glands. So that's where the sympathetic system is involved in all this. So we've also got, wherever there's acetylcholine, there's going to be acetylcholine esterase. So this is going to be present in your somatic system and your autonomic system as well. And this is going to be inhibited by your neostigmine. So neostigmine inhibiting the action of acetylcholine esterase, so the enzyme that breaks down acetylcholine at the neuromuscular junction, is going to allow for an increased amount of acetylcholine to be present at the neuromuscular junction. So the acetylcholine isn't getting breakdown by the acetylcholine esterase, it increases. It can then outcompete the neuromuscular blocking agent. So for your non-depolarizing neuromuscular blocking agents, you can give neostigmine. It increases the amount of acetylcholine at the neuromuscular junction. Acetylcholine can then outcompete because there's just more of them, and then you can get regain of your muscular strength, which is what you want. What you don't want, though, is the blocking of acetylcholine esterase within the autonomic nervous system. Therefore, if you're inhibiting the acetylcholine esterase in the autonomic nervous system, then you're going to increase the amount of acetylcholine that can then bind to the muscarinic receptors. So the muscarinic receptors are responsible for essentially all these symptoms. So there's the acronym dumbbells. So diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, lethargy, and salivation. So we don't want all our patients to experience that. So we give something to inhibit that response, and that drug is glycopyrrolate. So we always give neostigmine with glycopyrrolate. And what glycopyrrolate does, it's an antimuscarinic. So it's acting specifically at the muscarinic receptor, and it's an antagonist at the muscarinic receptor. So even though there's more acetylcholine at the neuromuscular junction, the acetylcholine still can't bind to the muscarinic receptors because they're being antagonized by glycopyrrolate. And therefore it keeps us happy and the patient's happy. So the other reversal agent that we can use is gammadx. So it's called it's a gamma-cyclodextrin. Essentially what that means, it's multiple sugar structures arranged in a circle. So it's got this unique configuration, and it's got this perfect lock and key fit for rocuronium. Therefore, it can bind perfectly with rocuronium and to a lesser extent vecuronium and pancuronium to form this complex. And the cool thing about it is because unlike neostigmine, gammadx is very rapid onset within a few seconds, and it can reverse deep blockade and can even reverse profound blockade. So if you give that massive dose of rocuronium we're talking about for a rapid sequence induction, and let's just say you're really struggling to intubate the patient and you need to wake the patient up right then and there, you can give 16 milligrams per kilogram of gammadx and reverse the rocuronium, which is pretty cool. So it's changed a lot of anesthesia, and it's a relatively new drug. It's only been introduced within the last 15 or so years, and it has profound impact on many factors of anesthetic care. So this is, again, just going back to what we did for this specific case. So we induced the patients, we gave them a hypnotic agent, an analgesic, and a muscle relaxant. We maintained them, again, maintaining that anesthetic triad. And on emergence, we want to reverse that neuromuscular blocking agent. So we're either going to give neostigmine with glycopyrrolate if we've given a non-depolarizing neuromuscular blocking agent, so either ROC-VEC, ATRAC, or CISAT, or we're going to give gammadx for either rocuronium or vecuronium if we've used those drugs. So we'll move on now to local anesthetics. So local anesthetics can be classified as either amino esters or aminoamides. So amino esters consist of cocaine, procaine, chloroprocaine, tetracaine, and they've got relatively shorter duration of actions, and they're associated with allergy because their metabolic byproduct is called para-aminobutyric acid, and that's associated with allergy. And then you've got your aminoamides, lignocaine, prilatane, etidocaine, mepivocaine, ropivacaine. But importantly, not many of them are very relevant at all, particularly for the junior critical care trainee. So we'll focus on these three: lignocaine, bupivacaine, and ropivacaine. So they're all amino amides. So amino amides, so they're amides, they have this amide structure, whereas esters have this ester structure. But lignocaine, bupivacaine, ropivacaine are all amino amides. So if we were to just grossly classify these three drugs, so going from lignocaine, ropivacaine to bupivacaine. So bupivacaine, it's slower in onset, it's more potent, it's got a longer duration of action, but it's also the most toxic. Whereas lignocaine, it's faster onset, it's less potent, it's got a short duration of action, and it's less toxic. We measure toxicity of local anesthetics by something called the CC to CNS ratio. So it's called cardiovascular collapse to CNS symptoms. And essentially it's the amount of dose or concentration within the plasma between when you get an onset of CNS symptoms to the point where you get cardiovascular collapse. So it's a relative proxy for the safety of the anesthetic drug. Then we can think about how local anesthetics work. So this is so in terms of anesthetics onset of action, the rate at which a local anesthetic, the speed at which a local anesthetic acts is dependent on its lipid solubility across the lipid bilayer. And its lipid solubility is dependent on its amount of ionization within the plasma. So the plasma has a pH of 7.4. And if you can think back to your days of looking at the Henderson-Hasselbalch equation, then you can correlate the pKa of each specific drug with the amount of which that drug will be unionized at a pH of 7.4. The specific numbers aren't really relevant. Lignocaine has a lower pKa than bupivacaine, and because they're both bases, it means that lignocaine is more unionized compared to bupivacaine at a pH of 7.4. Therefore, it's more able to cross the lipid bilayer. So it's able to be in this unionized form, cross the lipid bilayer, and within the cell, it then becomes ionized again, and then it binds to the intracellular component of the voltage-gated sodium channel, therefore inhibiting conduction across the membrane. So in terms of specifics for each specific drug, so lignocaine, the good thing about lignocaine is that it's less toxic and you can give quite high doses of it. But if you can even give higher doses of it if you're mixing it in with adrenaline when you're doing regional blocks. So the adrenaline works twofold. So it reduces the toxicity. It also reduces the bleeding at the site, and it's also going to increase the duration of action. And it's increasing the duration of action because for all the local anesthetics, for their offset of action, essentially they need to diffuse away from the site. But to diffuse away from the sites, you require blood vessels and blood to supply that area. If you vasoconstrict the area, then there's no blood that's moving. So therefore the lignocaine sticks around. So therefore it's going to have a longer duration of action. And therefore less is getting taken up in the plasma. So therefore there's going to be less toxicity as well. So bupivacaine is essentially the only anesthetic that you'll be seeing in spinals. Some people still use lignocaine, but lignocaine is associated with something called transient neurologic syndrome. So most people you'll find will use bupivacaine for their spinal anesthetics, and it can come in two different forms: heavy, and what that simply means is that it contains glucose, or plain, and plain doesn't contain any glucose. Bupivacaine can also be given in epidurals and regionals. So this image on the slide just shows this difference of a spinal anesthetic and epidural. So spinal, you're going into the arachnoid space and you're getting CSF, whereas epidural, you're sitting above the dura and you're going into this potential space beyond the ligament flavin, but before the dura. So you're going into this potential space there. Ropivacaine can be used for epidurals or regionals, and all three of them the surgeons will use all three of them in varying combinations depending on what they want. So importantly for local anesthetics, it's good to have an idea of the different type of nerve fibers that you're blocking, because it becomes clinically relevant. So there's grossly 3 different types of nerve fibers, type A, B, and C. And type A contains 4 different subtypes called the alpha, beta, gamma, and delta. So going from A to C, C fibers, they've got the smallest diameter and they've got the slowest velocity. Whereas the A alpha fibers, they're the biggest diameter and they've got the fastest velocity. So you can imagine that if you're like a local anesthetic molecule, it'd be a lot more difficult to block a very large nerve fiber, whereas a lot easier to block the smaller ones. So that's why your sympathetic, your autonomic nervous system is blocked first. So you'll get a drop in your blood pressure essentially straight away after you get the spinal anesthetic, because you're blocking your C fibers first. You then will see a change in the patient's perception of cold and pain. You might have seen someone, if you've done an obstetric term, you'll see an anesthetist or the anesthetic nurse grabbing a cold, like a cold block of ice, and then testing the block that way. And that's because the cold runs on, the sensation for cold runs on the same fibers as pain. So therefore, if you have no sensation to cold, you must also have no sensation to pain. And interestingly, motor is going to be blocked last. So there is something, you might have heard something called a walking epidural. And what that means is that you've got a patient who's adequately analgesed. So you've hit the pain fibers, but you haven't hit the motor fibers. So therefore, you're sort of acting sort of in this middle zone here as well, which is quite interesting. The last thing I'm going to talk about is about the drugs affecting the central nervous system. I won't talk about this for too long. It's quite a big topic, but the main thing is that your blood pressure is maintained by 2 parameters, being your cardiac output and your total peripheral resistance, essentially being your peripheral tone. And your cardiac output is dependent on 2 factors, your heart rate and your stroke volume. So if we want to affect your central nervous system via sympathomimetics, so there's 2 primary ways that we do this. Either via targeting the alpha receptors, the alpha adrenaline receptors, and that's going to be the main site of action of your vasopressors, such as noradrenaline or metreminol. And then you've got your inotropes, which are going to increase your blood pressure by increasing cardiac output. And they work by binding to the beta adrenal receptors, and they increase your heart rate and contractility, so affecting this part of your pressure. And these are some examples of commonly used inotropes and vasopressors, but this might help conceptualize it a bit better, or maybe not. So you can think of each sympathomimetic as acting on a sort of spectrum. Some are more vasoconstrictive, some are vasodilatory, and some are positive inotropes. And you'll see each of these drugs used in the intensive care environment or in anesthetics. So you've got your vasoconstrictive agents. So these are acting on the alpha-1 receptor, and these increase your systemic vascular resistance. You've got your positive inotropes, and these are acting on your beta-1 receptors, increasing cardiac output, heart rates, via increasing your heart rate and inotropy. And you also got these vasodilators. So beta-2 is quite interesting. It's actually a vasodilator. So unlike the alpha-1, so your sympathetic nervous system is often trying to do 2 separate things at once. So when you're in fight or flight mode, you want to reduce the blood flow to your gastric organs, so your splanchnic organs. So you don't want to have blood flow to your stomach or to your bowels or to your spleen. So you send out the noradrenaline and adrenaline, and they bind to the alpha-1 receptors, and they increase the tone to your splanchnic organs. And therefore that increases the amount of blood in your central circulation. But at the same time, you want to increase your blood supply to areas of increased metabolic demand and to your muscles as well. So your muscles have very high concentration of beta-2 receptors. So you actually want to reduce your systemic vascular resistance to those tissues. So beta-2, drugs that bind specifically to beta-2 will actually reduce your systemic vascular resistance. A good example of that is milrinone and dobutamine. So milrinone and dobutamine, they're called inodilators. So they cause increase in heart rate and contractility, but they also reduce your systemic vascular resistance. And this becomes relevant for patients who are experiencing cardiogenic shock. So patients who have significant, who've gone major CAG surgery, they're still maintaining very sluggish heart, and it's just not coping. If you gave someone a vasoconstrictor with a failing heart, then that's one way to sort of push the heart over the edge. So you want to try and avoid that. So that's why for patients with cardiogenic shock, you want to give something that's going to increase contractility, but also reduce systemic vascular resistance. At the other end of the spectrum, you have drugs that increase inotropy and increase contractility. The best examples of those is noradrenaline and adrenaline. So that's epinephrine here. When we're in theatre, unfortunately, we don't have central lines for all our patients. So we need to give drugs that act as sympathomimetics, but are also safe to give peripherally. So there's three main types of sympathomimetics that we give in theatre. So there's metreminol, also called aramine, ephedrine, and phenylephrine. The metreminol and phenylephrine, they're acting purely on alpha-1, essentially on alpha-1 only. So they're going to increase systemic vascular resistance. Whereas ephedrine also acts on beta-1 and alpha-1. So that's if you give that, you're going to see an increase in heart rate and contractility, and you're going to see an increase in blood pressure from that perspective. Importantly, for metreminol and ephedrine, they both have tachyphylaxis. What that means is that it's exhaustible. So if I gave a whole stick of ephedrine, and then I try to give another whole stick of ephedrine, I probably wouldn't see any effect after the second stick. And the reason for that is that you have, the way these drugs work, metreminol and ephedrine, is that they're called non-indirect sympathomimetics. So they work through a mechanism that is dependent on your stores of noradrenaline. So they're therefore not really acting directly on the alpha-1 and beta-1 receptors, but acting indirectly by increasing the amount of noradrenaline at the autonomic sinus. And you have a very limited store of noradrenaline at that sinus. So therefore, if you exhaust that store out, the drug's just not going to work because it doesn't have much direct effect at all. So we give these drugs, we can give these drugs peripherally, whereas if you try to give a drug like adrenaline or noradrenaline through a peripheral drip, then you're at risk of causing necrosis to the tissue. So people try to avoid that unless absolutely necessary, and instances where that's necessary would be situations such as a cardiac arrest, where a patient's lost output and then you're giving peripheral adrenaline. It's important whenever you're giving people, whenever you're treating blood pressure issues, you also need to be mindful of what you're actually treating. There's no point, like I said before, there's no point giving a vasoconstrictor to someone who's in cardiogenic shock. Same with hypovolemic patients. There's no point giving someone heaps and heaps of vasopressors if it's a fluid-related issue. You need to give fluid if it's a fluid-related issue. So it's all, and obstructive shock, there's often an underlying cause which you need to treat, such as a PE or a tamponade or a pneumothorax. So keeping that in mind, whenever you're treating blood pressure, whenever you're managing blood pressure issues, you need to know what blood pressure issue you're treating. And that's it. That's it. That's just a rapid overview of those three topics.
Thank you. That was all really broken down nicely. It was really digestible. So I guess we'll move on now to a bit of question time. Going to Slido, I'll read them out. Right, so our first question is, could you please explain when/why you would use a gas induction?
So there's a couple of reasons why you might consider a gas induction. The most common one would be in the pediatric population, where you're unable to get IV access in the patient because as the kids often aren't cooperative with putting in a drip. So often for kids, say between 2 to 5, would be a common age group where you can't even negotiate putting in a drip. So for those patients, the gas induction is a way to facilitate getting the patient to sleep and then allowing us to put in a drip. So we'll still always put a drip in, but it's sort of a temporizing, a way to achieve anesthesia. But we also need to get a drip because that's going to be our rescue if anything is to go wrong. Other consideration is something called a co-induction. So you might see people for very sick patients when you're inducing someone to give both sevoflurane and propofol at the same time. So there's an argument that giving a huge slug of propofol causes a large hemodynamic change in that patient. So if you were to start with the gas induction, get a patient sleepy, but then sort of finish the induction process with a dose of propofol, that can be perhaps a smoother transition from induction, from awake to general anesthesia.
The next question is, do people have allergic reactions to gammadx? And alternatively, if people are having allergic reactions to rock, would you give gammadx in that situation?
So you can have anaphylaxis to gammadx. So that it's known as a major side effect of gammadx, and all the muscle relaxants have a risk of anaphylaxis. In terms of the main causes of anaphylaxis in theatre, the top two it's antibiotics and it's neuromuscular blocking agents. So the risk is pretty significant. So they say maybe around 1 in 3,000 chance of anaphylaxis to rocuronium. A bit more common with succinylcholine, but perhaps less common with vecuronium and a lot less common with cisatracurium and atracurium. So if someone's having anaphylaxis to rocuronium, the recommendation is to not give gammadx. So I think this has been studied, and there's a recommendation to do not give gammadx, just focus on providing ALS care and getting the adrenaline into the patient.
The next question is, hi Patrick, could you please explain why you wouldn't use vasopressors for cardiogenic shock again? Thanks.
Yeah, so if you think of, so what a vasopressor is doing, it's increase your systemic vascular resistance. So you have your heart and it's pumping, and then you've got your systemic vascular resistance, which is the tone, and your blood pressure is a combination of those two factors. If you've got a failing heart, so it's not contracting very well, and you give someone a vasopressor like noradrenaline or even adrenaline, and you increase that tone and you've got a failing heart, it simply can't pump the blood forward. So then you'll go into acute heart failure, and then you'll also impair your coronary supply as well. And that will also increase the amount of work that your heart needs to do as well. So essentially, it's your heart's having to do a lot more work. And if it's a failing heart, it essentially doesn't have the capacity to do more work.
The next question is, can you please explain more about neuroendocrine reflex?
I was hoping no one would ask about that. It's a bit more complicated. So neuroendocrine reflex. So if you think of like baroreceptor reflexes, so you could say that's a neuroendocrine reflex, particularly when it feeds back into your renin-angiotensin RAS system. Another example would be the AMP reflex. And yeah, they're the two examples I can think of. It's not as relevant as the other two, somatic and autonomic, but it does play a small role.
The next question is, could you please explain why ketamine plus rocuronium has become standard therapy for intubation in COVID patients?
That's not true at St. Vincent's. Which is where I work. I'm trying to think of a good example, good reason as to why that would be the case. I guess the good thing about ketamine, I actually can't think of a good reason as to why that would be the standard for COVID cases. I actually can't think of a good reason. Because the advantage of ketamine is that you can give it and you can maintain spot ventilation of the patient. So maybe if you're worried about having a difficult airway, then ketamine may be a way out. But it's definitely not the policy at St. Vincent's.
Okay, I think we can do one more or two. What is the indication for TIVA?
So there's multiple indications for TIVA. So TIVA is total intravenous anesthesia. And most of the time if the way you can think about it is essentially what you're doing is you're avoiding all the adverse effects of giving a volatile anesthetic. So a potential reason would be someone who has malignant hypothermia. So the volatile anesthetic agents can cause malignant hypothermia. So that would be an indication for TIVA. Volatile anesthetic agents are very nauseating. So people who've had significant post-op nausea and vomiting, it would be a good reason to use TIVA anesthetic. Other reasons might be surgical indications. So the volatile anesthetics cause a lot of vasodilation in the brain. So if you've got doing a craniotomy on a tight brain, someone who's had a big subarachnoid bleed, then you want to minimize the amount of vasodilation as per the Monro and Kelly doctrine. So essentially you've got a fixed vault in your head. If you cause lots of vasodilation of the blood, then that's going to put more force on your fixed vault, and that's going to lead to more ischemia. So essentially for patients having big cranie surgeries, especially, or if they've had big bleed, then TIVA would be a wise decision.
All right, we'll finish with this last question then. And that is, hi, why is PR analgesia not so commonly used in this country as in other countries of the developed world, for example, in the context of obstetrics?
What does PR, what do you mean PR?
PR analgesia.
Prolonged release?
I'm not quite sure. Whoever asked that, if you'd like to comment, like again with what PR meant. Parapyractyl?
Oh, parapyractyl. It's still used in obstetrics. I see it used from time to time. So you can give some medication. So the rectal route, it can bypass first. It can bypass first pass metabolism. It's sort of like a gateway into the bloodstream, where if you were to take an oral tablet, then it would have to be taken up by the gut. Then it would have to go through the liver, get metabolized, and go into the blood. So PR bypasses that process, so you can go straight to the blood, and it's obviously not quite as invasive as IV, but for some people it may be more invasive. I guess the issue with that, it comes down to patient experience and patient preference. I guess we'd like to know that a patient has, it adds an extra variable where you're uncertain exactly what medication the patient has received or not. Then it's also dependent on bowel function of the patient. So it's something that, I don't know, in theatre, like during obstetric cases, it's very common to see them administer PR like non-steroidal to help with post-operative pain. But that's because the surgeon is right there, is able to deliver it, and it's been shown to have improved post-op pain. But to continue that post-operatively, I know it becomes quite an invasive thing for the patient, I reckon. So perhaps cultural differences. That's the main thing I can think of.
All right. Well, unfortunately, that's all we have time for tonight in terms of questions. But thank you, Patrick, again for the presentation. It was really helpful, as before, that was broken down and presented in diagrams and tables. And it was, great to get a bit closer to understanding that mysterious drawer of anesthetic drugs.
Very good. No worries. I hope it was helpful.
And on behalf of PVACCS and everyone, on behalf of PVACCS, I'd also like to thank everyone who attended tonight. Stay tuned for our final event of the series, which is P for Pain, on October the 7th. And we are also really close to announcing our final event of the year, which is an Anesthetics and Critical Care Careers Night. So keep an eye out on our Facebook page and our newsletter, as we'll be announcing that in the next few weeks. And you can sign up for our newsletter mailing list by signing up as a member of PVACCS, which is completely free. And last of all, this session has been recorded and it will be uploaded to our YouTube account in the following week or so. Thank you again to all attendees and Patrick, and have a good night.
See you guys.
Thanks so much, Patrick.
No worries.